and is characterized mainly with the pruritus, eczematous lesion, and it is often associated with other atopic disorders such as bronchial asthma and allergic rhinoconjunctivitis, known as atopic triad. It's a very common condition. We see patients with atopic dermatitis in our daily practice, and majority of the patients present and diagnosed before the age of 2 years. About 3 to 7% occurs in adults. Risk factors include multiple genetic and environmental factors. 40 to 70% of the patients have positive family history of atopy. It could be bronchial asthma, atopic eczema, or allergic rhinoconjunctivitis. And defects in the filaggrin gene have been shown to cause epidermal barrier disruption, which is the key abnormality in the development of atopic dermatitis. Environmental triggering factors include climatic changes, irritants such as fragrance and harsh detergents. Infections could be bacterial, viral, or fungal infection, aerol agents like pollen, air pollution, and dust mites. Now, pathogenesis is very complex and multifactorial, but basically we have 4 main contributing factors. We have genetic susceptibility, environmental triggering factors, impaired barrier function, which leads to immune dysregulation and skin inflammation. Now, filaggrin is the major structural protein of stratum corneum and contributes in the formation of natural moisturizing factor, which maintains skin hydration and low pH of the skin. Now, this is an image of stratum corneum. It is composed of the corneocytes, densely packed with proteins and lipids such as free fatty acids, cholesterol, and ceramides. When we have disruption in the stratum corneum, this leads to impaired skin barrier function, increase in transepidermal water loss, and dryness of skin. Also, we have increased percutaneous penetration of the allergens, irritants, and microbes through the skin. This image shows there's a defect in the skin barrier, and we can see there's increased permeability of the allergens and the microbes through the skin. This leads to an abnormal immune response of both innate and adaptive immunity, particularly T helper 2, and release of cytokines, mainly IL-4, IL-13, and these mediate inflammation and epidermal barrier disruption. Now, according to American Academy of Dermatology 2014 guidelines, we have to consider the following features in the diagnosis of atopic dermatitis. Essential features, these are features that must be present. And pruritus is the cardinal symptom. And as you know, it's a greater burden to the patient and also to the caregivers. Eczema could be acute, subacute, or chronic, typical morphology and age-specific patterns. The distribution usually varies according to the age. In infant, mostly involves the cheeks. In childhood phase, it involves the flexural areas such as antecubital fossa, popliteal fossa. And in adult, we have hand eczema with flexural involvement. It's a chronic disease with intermittent cause of exacerbation and remission. These are clinical images of acute eczema in an infant. We can see there's erythema, oozing, and crustation, mainly involving the cheeks and sparing the nose and nasolabial fold. And in dark pigmented skin, the erythema usually appears as dark brown or violaceous in color. Here we have a widespread subacute eczema, mainly involving the antecubital fossa and the trunk, and characterized mainly with erythema, scaly, excoriated papules, and plaques. And due to chronic rubbing and scratching, the skin becomes thickened, hyperpigmented, and increased skin marking, what we call lichenification. We can see lichenification here involving the dorsum part of the hand with post-inflammatory hypopigmentation. Also flexural involvement, the popliteal fossa, the antecubital fossa, and the neck. Important features, these are features that support the diagnosis. We have early age of onset, personal or family history of atopy, and dryness of skin. Associated features and non-specific features could be keratosis pilaris, pityriasis alba, hyperlinear palms, periocular, and perioral changes. Here we can see pityriasis alba, usually characterized with ill-defined hypopigmented patch, mainly involving the face. Keratosis pilaris, characterized with follicular pattern papules, mainly in the upper outer arm of the. And here we have periorbital eczema, characterized with lichenification and infraorbital fold, also known as Denny-Morgan fold. Here we can see there is lichenification involving the perioral and also infraorbital. We have to exclude the following condition as they look like atopic dermatitis. We have scabies, seborrheic dermatitis, ichthyosis, cutaneous T-cell lymphoma, psoriasis, and photosensitivity disorders. Now, as you know, scabies is a very common condition and usually misdiagnosed with atopic dermatitis. Basically, patients with scabies present with sudden onset of itchiness, with other family members also itching. And we have to describe the morphology and also the distribution so as to differentiate from atopic dermatitis. In scabies, usually patients present with polymorphic lesions, means the patient presents with excoriated papules, nodules, and mainly distributed in between the finger webs and in skin folds, especially the armpits, the genital. And when we see papulopustular eruption involving the palms and soles in an infant, this is highly diagnostic of scabies. Seborrheic dermatitis is also a common condition in infants, usually misdiagnosed with atopic dermatitis, and presents with erythematous, scaly patches with yellowish, greasy scales, mainly involving the scalp, known as cradle scalp, intertriginous areas, and also the face, mainly involving the eyebrows, nasolabial fold, and postauricular areas. Now, this is photodermatitis. It will be photoallergic or phototoxic dermatitis. And its eczematous lesion mainly involve the sun-exposed area. We can see there's involvement of the face, the V-shaped area, and there's a clear demarcation between the sun-exposed and the sun-hidden area, plus the extensor part of the extremity. You can see there's lichenification with a clear demarcation line. Now, criteria for diagnosis of atopic dermatitis, we have Hanifin and Rajka criteria, where we have major and minor criteria. 3 major and 3 minor is diagnostic. UK Working Party criteria, the patient must have an itchy skin condition for the last 12 months, plus 3 or more of the following: early age of onset, flexural involvement, xerosis of the skin, personal history of atopy, and flexural dermatitis. Now, management of atopic dermatitis, it is very important. At first consultation, we have to educate and counsel the patient and the caregivers that atopic dermatitis is a chronic disease with chances of intermittent flares. Therefore, we have a basic approach which involves skin hydration with moisturizer, and you have to educate the patient on how to identify and to avoid different triggering factors. We also have topical treatment, which are the mainstay of therapy, and in severe and resistant cases, we use systemic therapy. What we need is to stop the itch scratch cycle. From this diagram, we can see there is dryness of the skin, which leads to itching, cracking, that is impaired skin barrier function, increased permeability of the pathogen and the allergen through the skin, immune dysregulation, inflammation, and worsening of the itchiness. Now, the goal of treatment is to restore the skin barrier, to reduce the pruritus, and also to reduce the inflammation. This is an overview of European treatment guideline of atopic dermatitis. We have topical treatment, which includes basic treatment such as moisturizers, topical anti-inflammatory drugs, topical steroids, calcineurin inhibitors, phosphodiesterase 4 inhibitors. In case of resistance, moderate to severe, we can go for phototherapy or systemic therapy. And the only FDA-approved systemic therapy is dupilumab. Other systemic immunosuppressive drugs usually are used off-label, such as steroids, cyclosporin, azathioprine, MTX, and MMF. Now, skin hydration is the key component in the management of atopic dermatitis. Moisturizers have been shown to reduce transepidermal water loss, therefore improving the skin barrier function, and also to reduce inflammation. They reduce the erythema, the pruritus, the scaliness, and also xerosis. And it has been shown when used as long-term therapy, lifelong therapy, it reduces the need of using topical steroids. We have to explain to the patient on how to use moisturizer. Moisturizer should be applied at least 2 to 3 times a day, and preferably immediately after bath when the skin is still hydrated. Also explain to the patient that he has to apply moisturizer on both affected and non-affected areas, and it's a lifelong therapy. And an ideal moisturizer should be hypoallergenic, fragrance-free, and non-comedogenic. We should avoid allergy-provoking ingredients such as perfumes, lanolin, herbal extras, as these ingredients can induce allergic contact dermatitis and also flare-ups or exacerbation of the lesion. Now, ceramides containing moisturizer have been shown to restore lipids, hence improve the skin barrier function, and those containing glyceric acid have anti-inflammatory properties, therefore they improve the signs and symptoms of eczema. Also, you have to advise the patient to avoid prolonged hot shower bath and to avoid use of harsh detergents or harsh soaps. And we recommend a hydrating bath with mild, gentle, non-alkaline cleanser, and to apply moisturizer immediately after bath. Now, topical steroids, these are the mainstay of therapy in atopic dermatitis. Here we have a table. We show different potency. We have mild, we have moderate steroid, we have potent, and very potent steroid. In severe acute flares, we prefer to use potent steroids for a short duration, and when there is improvement of the lesion, we reduce the frequency and the potency of the steroids. Areas such as the face, skin folds, and the genitalia, these are high risk of skin atrophy, therefore we prefer to use low potent steroids. Ointments are more potent in compared to creams and lotions, and are used in case of thick lesions. And creams, exudative lesion, oozing, we prefer to use creams. Lotions, when we have hairy areas such as the scalp, we prefer to use lotions. Topical steroids, they are fast-acting, effective, control acute flares. Side effects include perioral dermatitis, glaucoma, skin atrophy, telangiectasia, and stria. Now, calcineurin inhibitors, these are topical immunomodulators, and have been shown FDA approved in the treatment of atopic dermatitis. We have tacrolimus, pimecrolimus. They have a very good safety profile with no risk of skin atrophy. Therefore, they can be used in sensitive areas such as face, genital, and skin folds. And due to safety profile, they can be used as a maintenance therapy, long-term therapy. For example, once or twice a day for 2 days has been shown to reduce exacerbation and improve quality of life. Dupilumab, this is a biologic target therapy that inhibits IL-4 and IL-13. And this molecule is not yet available in our country, but it has been FDA approved in the management of moderate to severe resistant atopic dermatitis. When used in conjunction with topical steroid, have been shown to have significant improvement in signs and symptoms of eczema, usually given subcutaneous at a dose of 300 milligram every other week with minimal side effects. And this is a take-home message. Physician, we should always optimize topical therapy before we consider systemic medication. Moisturizer is the key component and cornerstone in the management of atopic dermatitis. Patients who fail to respond should be evaluated for exacerbating factors such as infection, and also to rule out other diagnoses such as allergic contact dermatitis. Thank you.
Okay, shukran, Dr. Ali. We'll leave the questions to after the last presentation. Go mute. Kenya Association of Muslim Medical Professionals. Bringing you next, Dr. Salma Bashir, clinical psychologist. We're working with her closely for many patients. Please remember, 60 to 65% of chronic illnesses that we paid so much attention in this meeting are suffering mental issues. So, just to show us how small is the NCD burden, I want everyone with no father, mother, sister, brother, aunt, uncle who does not have hypertension, diabetes, kidney, or cancer. Any one of us who has that condition, please stand up. If you have that condition that no one in your family has diabetes, kidney, heart, or cancer, to stand up. And that's how heavy the burden is in our society. Can you imagine? It's not the 16% to read, but it's every household has been touched. And those people are depressed. Imagine it's easier to take Kalmatis every day, but it's not easy to take antihypertensive pills. We blame them. Oh, you don't want to, you are not compliant. Between me and you, if these medics today, they're in pain, how many will take Panadol? Less than 50%. And that's the same thing to our patients. So please, Dr. Salma, your floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Before I start this presentation, I'd like to read out a hadith which is going to tie up the presentation, the start of the presentation, and then we move on towards other psychological issues. If you'll allow me, I'll just read from my phone. Okay? So this was narrated by Abu Juhayfa. The Prophet ﷺ established a bond of brotherhood between Salman and Abu Darda. Salman paid a visit to Abu Darda and found Darda dressed in shabby clothes and asked her why she was in that state. She replied, "Your brother Abu Darda is not interested in the luxuries of this world." In the meantime, Abu Darda came and prepared a meal for him. And Salman said to him, "Please eat, for I am fasting." Salman said, "I am not going to eat unless you eat." So Abu Darda ate. When it was night, Abu Darda got up for the night prayer. Salman said to him, "Sleep," and he slept. Again, Abu Darda got up for the prayer, and Salman said to him, "Sleep." When it was the last part of the night, Salman said to him, "Get up now for your prayer." So both of them offered their prayers, and Salman said to Abu Darda, "Your Lord has a right over you. Your soul has a right on you. Your family has a right on you. So you should give the rights of those who have a right on you." Later on, Abu Darda visited the Prophet ﷺ and mentioned that to him. The Prophet said, "Salman has spoken the truth." And that is the backdrop, which I'd like to start my, sorry. So this is it. We're talking about life balance between, and this is the story of Salman and Abu Darda, where he says, your Lord has a right on you, your soul has a right on you, and your family has a right on you. So you should give the rights of all those who has a right on you. This is by Al-Bukhari. So talking about, when you talk about your Lord having a right over you, we're talking about worship and ibadah. And what is ibadah? Worship, it is a comprehensive term which envelopes everything that Allah loves and is pleased with. Whether what you're saying, your actions, working, whatever it is, that is part of ibadah. And again, it says, Allah says, "I did not create jinn and humans except to worship me." That is in the Quran. And that is an ibadah we should all have. And then your soul has a right over you. Yeah? So there is no blame on you for seeking the bounty of your Lord during this journey. People think that you should not do other things when it's come, you know, Islam is an all-encompassing religion, where work is part of. Work is part of our ibadah, and that our soul has that. But seek through which Allah has given you the home of the hereafter, and yet do not forget your share of the world. That means that Islam talks about the here and now. You're working now, but you're also thinking about tomorrow. Okay? And your family has a right over you. Again, this is another hadith. Thawban reported, the Messenger of Allah, peace and blessings be upon him, said, "The best coin for a man to spend is the coin spent on his dependents, and the coin spent by a man on his mount in the way of Allah, and the coin spent by a man on his companions in the way of Allah." Again, this is a very, very important hadith. It talks about what are we making money for? Who are we going to spend it on? Okay. So that's also very important. So again, you know, creating wealth, working is a very important part of ibadah. Okay. So again, it is a sin. It is enough sin for a man to withhold from those dependent upon him. Again, we go back to the story of Darda, and she said that your brother has no time for luxuries in this world. So dressing up and making sure you spend your money in a way that is also allowed. So this now I come to that was the backdrop, and I'd like to talk about two things. Again, in the West, we talk about work-life balance, but in Islam, we refer to a total life balance. In the Western side, we talk about balancing between yourself, your work, your family, your friends, and we're talking about dividing time and focus between working, you know, and family and leisure activities. Just, okay, I'm going to rest at this time, I'm going to work at this time, I'm going to do this. So, you know, you follow some sort of program. But in Islam, we talk about a balance between the body, the mind, and the soul. And that is when I talked about the hadith of Abu Darda, that's what I'm talking about. How much do we give our bodies? Okay. Our minds, mentally, are we okay? And our soul, you know, we have to balance all three as Muslims. So what is the Islamic approach for work-life balance or total living a balanced life? In Surah Baqarah says that, "Thus we have made you the people of the middle." We are not supposed to we have to find a balance, and that is about the total, the body, the mind, the soul. We must look for a balance every time in our lives. And when people when people are stressed, it's because they're unable to balance this. You find that sometimes you overdo things spiritually and your family suffers. Or you are looking for work so much and other parts of your life suffer. So as Muslims, sometimes I wonder, our 5 prayers, do we take time to make sure that we're not seeing somebody doing Dhuhr time? Do we have time for Asr? Do we have time for Maghrib? Because that's very important. We are people of the middle. We don't overdo things. And again, your eyes have a right over you. I've talked about that. So this balance is very important as Muslim professionals. And now I'd like to talk about something about burnout, because a lot of medical personnel are burnt out. And when they come for therapy in Chiromo, at Aga Khan, wherever it is, most of them, it's about burnout. They are unable to balance things out. So there was a study by Afulani in 2021 that was conducted in Western Kenya. These are people, it was about the maternity workers, and they found that 85% of maternity workers in Western Kenya had moderate stress, and 11.5 had high stress. 65% of those staff experienced low burnout, and 19.6 had high burnout. That is very significant, because you can imagine in the maternity care, if you're unable to operate optimally and you have burnout, you're going to end up not working very effectively. I have a cousin who's a nurse, and she's a midwife, and I ask her, how do you do this, Laila? She says, you know, by the end of the day, if a patient is not going to listen to me, I will slap her. So she's tired. Does she take a break when she works? And I asked her, why would you slap her? She says, because it's a matter of life and death. So how are we doing these things, you know? Are you burnt out? Do the hospitals where you work recognize that you're burnt out? Another article published by the Harvard Gazette found that doctors' burnout cost the healthcare system $4.6 billion, okay? And this burnout has resulted in medical mistakes, misdiagnosing illnesses, prescribing the wrong medications, and not paying attention to essential details. And this is very serious for people in the medical profession. What is burnout, okay? It has been described as the neurological and physiological shift that happens in your body when you encounter triggers. Most important, burnout results is because of unhealthy boundaries. Do we know our boundaries? Can we say no when we're tired? Can we put a stop to things? Must we always be, you know, overworking ourselves? How do we handle? I talked to a medic in Mombasa, and she told me that she dreads going home, because when she goes home after a long day of work, her mom has lined up more relatives who need to be seen. Or she's called sometimes at 10 p.m., 11 p.m. We all go through this, don't we? Relatives calling us, come and check on us. What happens if this person says no? What watasemaje? What will people say? You know, they'll say that you're a show-off. So again, this is a very important thing. We must learn how to maintain healthy boundaries if we don't want to suffer from burnout. What are the causes of burnout? Not knowing when to say no. How many of you can say no, by the way? Show of hands. Thank you. Yes. Yeah, you have to learn how to say no when you have had more than you can handle. Okay? Not knowing how to say no, because you may say it in a very rude way, because you're very tired. Okay? And then prioritizing others over self. We don't take time to take care of ourselves. Okay? People pleasing, the superhero syndrome, I can do it all, I can make it. Unrealistic expectations of yourself. Yeah, why did you become a medic? You want to save the world. And not being appreciated for what you do. Okay? How do we manage stress? I'm going to bring up the Islamic perspective and the psychological perspective. Yeah? Surah Al-Rad talks about, you know, ala tatma'inna. Qulub. Yes, sometimes I'm nervous, that's why I'm forgetting some of this. Verily, in the remembrance of Allah, do hearts find ease. And that is so important. It is so, so important. I remember it worked so well for us during COVID. I approached my ustada, I asked her, what can I do? She told me, just say your istighfar. A lot of stress will go down, and it works. It's a tried and tested thing. Do recite du'as, because Allah is sufficient for us, and He's an excellent guardian. And we repose our trust in Allah. Ask yourself, am I really trusting Allah to help me out? It has to be sincere. That's why the chaplain said, how do you recite Surah Al-Fatiha? How sincere are we? Okay? And then morning and evening adhkar, very important. Let's talk about managing stress from the psychological perspective. Social support is very important. And many times, many clients who come to us for therapy, when you do an assessment, they have nobody they can turn to. They say, our families don't understand us. I can't talk to anybody in my family. They think I'm pretending. Some people don't recognize mental health as something that needs attention. So social support and then regular exercise. How many of you medics here work out regularly? Very few people. Something as simple as a walk, walking to work, will make a big difference. That is a workout, okay? Regular exercise, being involved in charitable and social activities, so you know how the other people, like Kammp, yeah? What Kammp does. I heard yesterday how they had some really good camps to help people, okay? Practicing gratitude. It's important that every day we make a gratitude list. What are we grateful for in this world? So you look for positives in your lives, your blessings you have, your health, okay? Managing your boundaries, learning how to say no, okay? Learning to recognize the fact that you're getting tired, your body is, you're getting regular flus, regular headaches, like Dr. Shaush said here. We work very closely with him. People go to him, heart palpitations, they want angiograms, I don't know, they want so many things, only to find out that it is anxiety, probably caused by not meeting your expectations, okay? And then very important, seeking professional support. Please don't stigmatize mental health. We are very confidential, and we are out there. We want to help you. And everybody goes through stress, including us. And we also go for debriefing, or we go for therapy when things become overwhelming. So please seek professional help. It is there, and there are many Muslims, mashallah, who are now therapists. So these are some useful links for you. I think I am done with my presentation. Thank you very much.
Thank you very much, Dr. Salma. So with a show of hands, again, how many of you, I'm talking for those who are married, either has a husband or wife, depending who you are, your wife or husband has not complained, hii kazi yako haiishi. Please. Please. So sometimes we get bothered, who bana complain to. But, yes, but please treat it. Please, you're booking you for a webinar. So, that's a very good comment. So, most of my colleagues will talk and say, bana, wife, you complain. But please treat that as a speed governor. You should be thankful inside, you don't tell them too much, that someone is telling you you're overspeeding and you don't see yourself. So when they tell you and they're bothered, is because they still have feelings for you. The day they will not have any feelings and keep quiet and let you walk, oh my God, you Amanda. Okay? So please watch out for ourselves. Own your title deed. Those boundaries, they're telling you to own your title deeds. Just know where you are. It's not bad to say no, and it's a process. And I'm also learning it. Okay? So with that, we're going to our last part of our session. Sister Fatma Kibwana, Head of Physiotherapy and Rehab, she'll tell us about ergonomics in healthcare.
Assalamu alaikum wa rahmatullahi wa barakatuh. So just to make the session a bit exciting, kindly all of you stand up. Please give me 3 minutes only to do this first, not from my presentation, yeah? Okay, so I know we are all a little bit tired. Some of us have not exercised in the morning, right? Yeah, so just take your next round. Yeah. Then the other way around. Yeah. Hold the ball up there with a wider stance. Give yourself space. Okay, then let's all move to the right. To the right, yes, then to the left. Again to the right, to the left. Again to the right, to the left. Hands on your waist. Okay, then just lift your leg up, out, and down. Okay, let's do that. Up, out, down. Up, out, down. People are not, they don't have stability. We are all unfit. Let's go again. Up, out, down. Up, out, down. Again, up, out, down. Up, out, down. Okay, just march on the spot. Okay, have a seat. Okay. As much as mental health is important, physical well-being is equally important. And probably by a show of hands, yeah, I'll repeat his question. Yeah, in the family or yourself, who doesn't have a musculoskeletal disorder? Raise your hand. Any musculoskeletal disorder? Good, everybody has some sort of. Yeah, okay, now to my presentation. So, globally, sorry, this is not the presentation. Kuna ya mwisho nimetuma jana.
You sent last night?
Yeah, last night
okay,
I sent.
I think it's in this one. She was saying you copied during break time.
So let's put it this side. Let's put on this one. Or just put there. No, they are in a different name. Continue without scanning.
So to save time, we'll start taking some questions as we wait for the slides for any of the two previous speakers so that we cut off on the end. Yes, Dr. Omar, please.
Thank you. I think mine is a comment and a point of reflection. So the comment is...
Dr. Omar, there's a request that you stand up so that we can see you.
Thank you. So mine is a point of reflection and a comment. So looking at, for example, the chaplaincy, and I'm proud to see that, because in the UK military, they have a imam, Muslim chaplain, and he supports the Muslim soldiers. And one of the good things is that the chaplain in the UK military is Imam Ali Omar. He's a Kenyan. His squadron leader, Imam Ali Omar, is a Kenyan. He's the rank of a major in comparison. And he has managed to get the UK military to allow soldiers not to work during Ramadan, given time to pray, given time for iftar and all of that. And also he came to me for guidance on eating and nutrition during Ramadan, and we managed to put down a policy for that. And then more recently he's come back to me so that we can write a policy for Hajj, for soldiers who want to go for Hajj, which is why I'm presenting what I'm presenting in the poster. And it wouldn't be surprising for you to know that he's also from Congo Air. So, and the point of reflection, the point of reflection is for Kammp to go to the Kenya Defense Forces to find out if they have a Muslim chaplain, because there are Muslim soldiers, obviously, in KDF. How are they being supported in their daily work, and in time of death, how are they supported? Thank you very much.
Thank you very much, Dr. Omar. So as a Kammp, please, I would love the contacts of that person, because we're developing a curriculum. So we've got in touch with some people at university in UK and Malaysia. Please share his contacts if he's willing, so we can develop networks. So it looks like Congo Air this time is shining.
Oh yeah,
but it's a message. It's a message that if you hear someone from Mathare, Kibera, Kibokoni, Congo Air, whatever, it's not that it's bad. And that origin does not define your tomorrow. In fact, it should push and do more. That's why people are surprised. Congo Air again? Yes. I wish everyone said where they're coming from, but you don't have that time. So, Dr. Amar, please.
I had a question, Dr. Bif, but...
Okay. I'm Dr. Amar. I'm not from Congo Air. My question is... Kibokoni, yes. My question is to Dr. Salma Bashir. Knowing that the numbers of government patients and private patients, we know that the government patient, we see there are so many. Now, how do we approach the media in terms of how the way we approach the government patient in terms of in comparing to the private one, that the mentality is that we are too harsh to the government patient because of now we have numbers and we are burnout, but the private ones, we see a few of them, like 5 or 6, and we give them the good care. How do we respond to the media concerning that issue?
Do I need to stand up?
Yes, please.
Thank you. By the way, is there anyone here from Team Changamwe? I'm from Changamwe.
MashaAllah, Changamwe. Yes.
Yeah, so yes, it's true. Right now, the government, the president signed the bill for Psychologists and Counselors Act, and I think there's eventually when we get stronger, because right now among psychologists there are so many different organizations, and one of the things that I know that they're working on is how then to roll out mental health services everywhere. But quite a number of hospitals now have got psychologists, and the idea is how can the psychologists and the psychiatrists in the hospital work together to come up with CMEs for the doctors. So I think the idea is if we can pick up this challenge for the psychologists and the psychiatrists who work with the government to lobby for some CMEs and for debriefing sessions to help the doctors, because doctors and medics are burnt out, and I think one of the most important things they lack is debriefing sessions. Dr. Nabila, isn't that true? So this happens a lot, and because doctors are very, very overwhelmed and burnt out. I hope that answers your question.
Thank you. So some of the challenges is when you send patients to a psychologist, they think they're crazy. So they'll always say that. So one of the things I tell them is I also go for debriefs, just because it's one of the things. Psychosis is different, but it's not unusual. Number 2, it's very common. It's needed. It's in our families, place of work, friends, it's everywhere. Question, please.
Assalamu alaikum.
Wa alaikum salam.
Stand reminder kuwa I'm still from Kongowea, first and foremost. Back to my question was, Daktari, there's a study I know that was done in somewhere, I think in one of the African countries, whereby they were using grandmothers whom were not said that kind of helpful to the society, but they were putting them in mental health to counsel and alleviate the psychological aspect of stress to youths more so. I think, do you know anything about it? Because I'm working with another psychologist in Pwani University who works in Kammp, is facilitating the study. I don't know. Yeah. I think we can.
Okay. So those big families were a good psychological support. Unfortunately, these days you'll go to a friend but not go to a cousin. You'll go to a neighbor but not go to an aunt. And there's a lot of benefits in that. And the best ajr, if you're doing any khair, it should be the people closest to you. Okay, and there's a lot of significance in that.
Assalamu alaikum wa rahmatullahi wa barakatuh. My question will go to Salma Bashir, and this is a practical question which happened around 1 week ago. I saw a patient, of course, palpitations, all that done, thyroid test. He came to me. As a physician, I noted that this patient had a psychological problem, and I referred the patient to you. So the patient asked me, where can I see her? So I told her, where are you coming from? She told me, I live in Nyali. So I told her, it's easy. You can see her in Chiromo. Told me, that mental hospital? No. Can I see her somewhere else? So this patient lives in Nyali. She was okay to go to Aga Khan to see you, but not come to Chiromo to see you. Can you comment on that, please?
Shukran, Doc. Actually, the matatus, when they drop people at Chiromo, one of my clients told me, she was told, ala, unaenda pale kwa wanda wazimu. Wale watu wa machizi. Yeah, there's so much stigma on mental health. And people, you know, Chiromo is also a wellness center. Yeah, people get admitted there for wellness retreats. I mean, you just, you know, you go through positive psychology, you're just tested, you're checked for everything. So I think this stigma is real. And if I can talk more about it, I remember we used to give talks in the Radio Rahma, Radio Salam, and we talk about depression, and people make calls and tell us, yote hiyo ni rubbish. Swalini, amka usiku, tawadha, uswali tahajjud, and Allah will solve all your problems. And again, we talk about Surah Ad-Duha, yeah? Surah Ad-Duha is all about our Prophet sallallahu alaihi wasallam feeling, you know, left out because he had not received a wahi for 6 months. And then that surah talks about how, you know, what he can do. You know, thy Lord has not forsaken thee. So I think we need to keep on educating people, and maybe I need to go back again to the radio stations. But Doc, your patient can come and see me at either Aga Khan or Health Source.
Yes. But it's a stage, eh? Boga kwa machizi.
Yeah. Yes.
Rif, please, last question, then we go, and we have cancelled Q&A session.
Okay, Chairman, I have. Actually, it's not a question, but Jazakallah khair, Ustad. What she mentioned about the spending on your next of kin. We have stages. Allah subhanahu wa ta'ala has given who is having more right. How many of you are your parents alive? Just by show of hands.
One.
Yeah? 1 or 2, I know. How many of you have spoken to your mom this morning?
Mom, no.
This morning. Please, I want to give you. Take care of that person. Allah subhanahu wa ta'ala has elevated 3 stages above the father. If you have children, tell your children, have you seen or what have you done for mom this night? That is the best place to spend. How many of us have given even a kiss or a massage to the mom yesterday night? For those who are with their moms. That is where to spend. These beautiful ladies you can see here, they go to the MCH and dress and breastfeed you in public for your sake. And when she becomes old, you think it is bad to associate yourself with that. Take care of that person. Thank you.
Shukran, shukran.
Thank you, thank you.
Come, mashallah. Is there any medical conference you'll hear such things? No. Please welcome to Kammp next year. Dr. Ibrahim.
This is to again, Salma. I mean, I think it was a very crucial talk. But there's a concept about, before burnt out, there's something called brown out. Maybe I don't know if such a concept exists. And number two, when you say manage your boundaries, what are these boundaries? Who sets these boundaries? And who do you discuss with about these boundaries?
But there, mental health, no one talks about it, but when it comes up, it takes the largest chunk of time. It's a symptom. Dr. Nabila, please make arrangements.
Shukran. I've heard of burnt toast syndrome. Like, you know, when you over toast your bread, you're unable to chew it. It's really painful sometimes, especially if it's sourdough. So burnt toast syndrome usually comes just before burnout. Yeah. So we need to be self-aware. When you find that you receive a call and you're like, I don't want to talk, I don't want to pick this call, you know, you're getting burnt out. When you find yourself irritable, you're hurrying people, you're getting burnt out. When you find that you always feel that 24 hours is not enough, you're getting burnt out. When you don't sleep well at night, when you have headaches, backaches, you're getting burnt out. Where there's no functional cause of that, you're getting burnt out. And the boundaries, who sets the boundaries? In the total life care we talked about, it's a balance. How do you balance yourself, your ibadah, you know, your soul, your family? That is how to create the boundaries. And for example, we talk about us being shepherds. When we have a responsibility, for example, if you're a parent, you have a responsibility to nurture your child, to spend time with them. So if somebody is going to stop you from getting to that responsibility, that's when you say, actually, no, this is time for. So you set the boundaries. And if you don't set boundaries, you become very resentful and angry. Like Doc said, how many of you come home and your spouses will tell you, endelea na hiyo kazi. They are very resentful now towards you because you're not giving them the time that they deserve. So they could be burnt out in a different way. So burnout is something that happens to us, and mostly it's because we don't set the right boundaries when we're dealing with people. But you can come and see me for a private consultation.
But there, one of the things in one of the sessions I went, we say God is fair, yeah?
Absolutely.
But someone is light, someone is dark, someone is short, someone is tall, someone is wealthy, someone is poor. How is it fair? So there's some things we say them. We may have faith. Faith is something that you believe but with no evidence. It's just that you're told and you believe, okay? But one thing that is fair and we can see and count is 24 hours.
Yes.
Okay? That God is fair and you can see, and any even crazy person sees this is 24 hours. So when you find yourself spending too many hours in something that you're a hero, like for example, clinic, just know that you have deducted so much from somewhere else. And find that balance for yourself. Okay? Balance for yourself, it's you and people around you. And sometimes there are those comments they'll throw that, look, you're overspeeding. Watch that as a boundary. But for sure, if you see a very word-hacking clinician, excellent, day and night he's serving all patients, all calls, all ECGs, for sure he's deducted so much from somewhere else. Okay? With all that, the end of our talk of this, we'll not have question and answers. Sister Fatma, are you sitting well in clinic?
Oh. Definitely, no, I can see the postures.
Assalamu alaikum.
No.
Assalamu alaikum. May I, MC, Dr. Shaush, may I? Here.
As she starts, I think it's important if you allow me to ask Abu Najma to share his contacts with people, because many patients get referred to Kenyatta Hospital from all over the country, and then they are stuck, they don't know what to do. So if his contacts are given to people, to medics in other hospitals, I think it's going to be help. We are referring you to Kenyatta, but here's Abu Najma's contact.
Okay, so please, Abu Najma, go ahead to that place, give your contacts that will be displayed on the PowerPoint. Please. Thank you.
Okay, thank you. So, we're going to look at the background, the musculoskeletal disease among healthcare workers, ergonomics, components of ergonomics, principles of ergonomics, and a conclusion. So looking at the disease burden, globally, we have 494 million people that had other musculoskeletal disorders in 2020, and that was an increase in total cases of 221 million in 1990. Yeah, cases of other musculoskeletal disorders are projected to increase by 115% from 2020 to an estimated over 1,060 million prevalent cases in 2050. Most regions were projected to have at least a 50% increase in cases between 2020 and 2050. Global age standardized prevalence of other musculoskeletal disorders was 47.4, higher in females than in males, and increased with age to peak at 65 to 69 years in male and female sexes. So in 2020, other musculoskeletal disorders were 6th ranked cause of years living with disability globally, and was associated with 83,000 deaths. So it's quite a burden, not just globally, looking even regionally. Yeah, we see quite a lot of musculoskeletal disorders. So I came across this journal, and occupational health is a neglect public health issue among healthcare workers in developing countries. And this has exposed healthcare workers in developing countries to various forms of hazards, which have had a negative consequence on their well-being and performance at work. So conclusion was developing countries should prioritize occupational health and safety issues by investing heavily into standard infection control measures and training of healthcare workers on work safety, mounting surveillance on occupational hazards, and implementing policies that will protect the safety of healthcare workers is also key. So looking at musculoskeletal disorders among healthcare workers, healthcare providers have a high prevalence, and incidence among healthcare workers is higher than in general population. But surprisingly, I mostly see the general population in my clinic than the healthcare workers. It's only when I meet them on the corridors, then they remember, oh, I have a neck pain, I have a back pain. Yeah, when they see me, it's when they reflect to their pain that they have. But they are good in sending patients, but not sending themselves to the clinic. Yeah. So looking at this, we have neck pain, 59%, back pain, which is upper and lower back, 55%, shoulder pain at 34%, wrist and hand pain. And these are really easy to overlook because you just feel like it's tiredness. Yeah, I'll just take a pill and I'll be fine, okay? Or maybe a doctor is not supposed to be sick. When I get a back pain, I go to the outpatient and somebody is asking me, a physio can get a back pain? But yes, we do get strains. It's not that we are immune just because we are therapists. Yeah, we do get injuries as well. And you need to seek help wherever you get a discomfort or an injury. So continued exposure to risk factors over a period of time, at the end of the day, it will lead to disability. So looking at the risk factors, we have forceful exertions, awkward work postures, repetitive motions, prolonged activities, localized contact stresses, segmental vibrations, and temperature extremes. And I think in our practice, we can relate to all these. Yeah. So reasons for this, we have long working hours in ergonomically challenging postures. You're concentrated on that surgery. You're busy. You want to take care of the baby on a CS, yeah, in that posture. You don't care about your back. You don't care that this height is not good for me. Maybe I need to sit. Or if it's standing, the bed has to be raised a little bit higher. Yeah, we don't put that into consideration. Flexed neck and elevated arm position when performing surgery, extremes of motion and contorted body positionings, prolonged standing. Yeah, so we can relate to this. This is what we do daily: static positions of the neck and trunk, associated frequent movements of upper extremities, and lack of education regarding surgical ergonomics. So I think this should be included in curriculums. Yeah. So what's ergonomics? It's concerned with understandings of interactions among humans and other elements of his profession to optimize well-being and overall system performance. So it's just matching the job to the worker and the product to the end user. So increasing productivity while maintaining health. So all this is interconnected. When you talk of ergonomics, we have the machine, the human factors, the task design. So all these have to, if balanced, we have a proper ergonomics. So the machine design, yeah, is it suitable for the human? Yeah, we are looking at human factors. Yeah, do you have the knowledge, yeah, to use that machine, or the knowledge for that task? Yeah. Then the task design, the environment itself. Yeah, is it designed for the human to come and work on that environment? So ergonomics look at three components, which are physical, cognitive, and organizational ergonomics. So on physical, we are looking at human body's response to physical and physiological workloads. So this includes repetitive strain, injuries from repetition, vibration, force, and posture. Then in cognitive, we are looking at mental processes and human capacities. The machines that have been developed, are they friendly to the user? Yeah, or is it so complicated that you cannot distinguish, like you cannot operate that kind of machine, so causing cognitive issues. Yeah, so cognitive ergonomics focuses on the fit between human cognitive abilities and limitation versus the machine task and environment. So organizational ergonomics, we are looking at organizational structures, policies, and processes in the work environment. So this includes teamwork, motivation, job satisfaction, shifts, scheduling, and ethics. So principle of ergonomics, always maintain an S-curve, whether you are standing, whether you are sitting. We do this a lot. Yeah, we do this a lot. And forget that you need to be at least upright. In sitting, people sit, you have a very good chair, orthopedic chair, you buy the best, but how do you use it? Yeah, you sit at the front. For those who use computers mostly, phones, our necks, yeah, causing a lot of neck pains. Yeah. So looking at procedures that we do every day, like injections, yeah, nurses working at on the bed of the patient, yeah, ensure that bed is raised. Yeah, if you don't have a working space, elevate the surface. Yeah, reduce the bending, the reaching, put things closer to you so that you don't have to reach for the items that you frequently use. So keep everything in easy reach. The ones that you frequently use, keep them closer to you. The ones that you don't use frequently, they can be a bit, put it on the side a little bit. The ones that you're using, minimize static and fatigue load, minimize pressure points. The gadgets that we use, pressures on our fingers. Yeah, use gadgets that are ergonomically well. When we are purchasing these equipments and all that, we put these things into considerations. So reduce excessive motion, provide clearance. When you're moving items, things should not be up. When you're seated, the area you are sitting, you should have clearance. When you stand up, you don't hit your head. Look into those considerations. Look at your office today, go back, look at it and see, can I reorganize this so that it can fit my work, I can sit properly, I can do my work without a lot of strain. So benefits of ergonomics, and this is just some of them: decreased injury risk, decreased mistakes, decreased lost work day, increased productivity, efficiency, and morale. We all know that we need to sit properly. We all know, we all have this knowledge, but how do we really practice? How many of us really practice this? Yeah? So this was a comparison that was done between knowledge and ergonomics practices, and you can see, adjust armrests, yeah, to around 90 degrees. We know we have to do that, but we don't do. Yeah. Backrest, the same. Straight wrist, when you're using your laptop, the mouse, yeah, you see people compressing on your wrist joint. The wrist has to be straight. You use it comfortably. Yeah, the height has to be adjusted. It has to be on that position. We have gadgets that do raise the laptops and all that. Use those. They will really help so that you prevent you from that posture. We're talking about the S-curve. Always remember about the S-curve. For it to stick in your mind, just imagine you are wearing a necklace and you want to show off. As you sit, as you stand, show off your necklace. Yeah? Yeah, so automatically you'll get the S-curve. Yeah? So in summary, physical ergonomics maintain proper posture and body mechanics while performing tasks. Use adjustable chairs and workstations to ensure proper alignment of body. Use ergonomic tools and equipment to reduce risk of repetitive strain. Avoid heavy lifting and use proper lifting techniques when necessary, and always call in for help. Something is heavy you cannot carry, carry two of you, and you are called in, please come and assist. Yeah, this is a heavy patient, work together, teamwork. Take regular breaks to stretch and move around to prevent fatigue and muscle strain. How many of us do that? We were here seated the whole day. The whole day. No one stood up to at least stretch and all that until you're going for a break, unless you're going for a break at 10 or you're going for lunch. That's when you remember to stand up and stretch a bit. So after, put it like a reminder even on your desktop. After every 1 hour, just a reminder, it's a stretch break. Yeah, stand up, stretch even in your office. Yeah, you don't have to go to the gym. Use the staircase, yeah? Walk instead of using the lifts. Staircase, walk, when you're doing the ward rounds, don't do the shortcuts. Take the longer routes, yeah? So it helps. Cognitive ergonomics use electronic health records and other digital tools designed with user-friendly interfaces. Ensure clear communication, information exchange among healthcare team members. Provide adequate training on new technologies and procedures to reduce cognitive workload. Encourage mental breaks and stress-reducing activities to maintain cognitive well-being. And organizational ergonomics, we look at implement efficient scheduling and workload management to prevent burnout. Promote teamwork and collaboration to reduce individual workloads. Provide a supportive work environment that encourages open communication and feedback. Ensure that healthcare workers have access to necessary resources and support for their task, and encourage a culture of safety and well-being in the workplace. So in conclusion, recognize musculoskeletal disorder signs and symptoms. You understand these musculoskeletal disorders hazards, and take steps to control musculoskeletal disorders hazards, and participate in the ergonomic programs. You have a strain, you have a pain, seek help. Don't take that painkiller and say it will go away. Seek help. Maybe it is your muscles are weak, maybe the way you are sitting, wrong postures and all that. Seek help and correct that. Thank you.
Thank you very much, Sister Fatima. I think I'll kindly book for the next skill session next year on how to teach medics to bend, operate, sit. There's a lot of that, huh? A lot. Operate, yes. But I have a surgeon, a friend, a very good friend. Whenever he goes to theater, he will say, Kiti pandisha, nipe, weka hapa, and those guys are fed up of him. For them, ujama ajisikia sana. Like the whole theater should bend the way he wants his chair here, he wants his height here, he wants his scope there. He doesn't want to bend, he just wants to turn like this. And according to them, he is wrong. Okay, so that awareness is needed. When you see someone like that, you need to admire and try to do something like that. Because we tend to not to adjust things the way it fits us. Okay, we tend to be, quotes and quotes, humble. Yet you're told to show your necklace. Okay, okay, a question for Sister Fatma.
Shukran, jazakallah khair. I just want to encourage and the point Sister Fatma put, that take stress breaks regularly. It's not just important for the musculoskeletal disorders, but also to prevent hemostasis and having thrombi, especially in your legs when we sit for long. So we've been encouraged, if you sit for long, after an hour, 1.5 hours, take a break. Take a walk, 10 minutes, come back. It has been shown to be very, very important. And especially if you're on a long flight also, that's also very, very critical to prevent thrombosis. We've known colleagues who've come from an 8-hour flight and straight to hospital because of pulmonary embolism from a DVT. Shukran.
Shukran.
Just a minute.
No, wait.
Okay.
Please also discuss about swala, the ergonomics of it. Thank you.
Yes.
So actually on you're talking about clothes and all that, I will encourage, I'll advise all healthcare workers, if you can, put on graduated stockings. It becomes like your daily clothing. The same way you're putting on the scrubs, that should be part of your scrubs, the stockings, either below knee or above knee. This really helps with your circulation, preventing the DVTs as well, varicose veins and all that, because we stand for long hours, we walk a lot, so that should be part of your, and it has to be graduated, not just any stockings. Yeah. So in regards to swala, yes, swala, actually I even saw it somewhere. It's like a form of exercise. The postures that we go, when you do ruku, and you're actually told to actually straighten your back. It's the S-curve that we are talking about. You don't go over, your hands should be at the knee. You do a proper ruku. You don't bend your
90 degrees.
Your knee down. It has to be 90 degrees at the hip joint. Yeah. When you are sitting down, it's 90 degrees at the hip. Then the legs are totally flexed. So you look at those postures, and they actually help, yeah, in making your body healthy. We look at when you ruku. When you sujud, yeah, your spine is properly aligned. It's straightened. Yeah, that's the best way to do. So stick to your swala, and it will really, really improve your physical well-being as well. Thank you for that.
Thank you. So with all that, we are coming an end to this session. Inshallah, I'm informing you about afternoon skill session. There'll be central venous cannulation, trauma. For example, if we were in Gaza, imagine we see pictures of our brothers and sisters on video clips. 10 people are coming. Who do you prioritize? Who should you take care of first? We can treat, we can give paracetamol. As in mass casualty, we have that session in the afternoon. As a clinician, how do you prioritize mass casualty? Who will be taken care of first, who you forego, and who will be kept aside? So that is in the afternoon. We have care of a dying Muslim patient. We have gynecological cancer screening, that is a big issue in our society. Diabetic foot evaluation, we have a lot of amputations that some of them can be prevented. And then basic ECGs for cardiac care. Next, inshallah, I welcome Brother and Dr. Nasir to take care of the next panel discussion that will be discussing health and moral compass, navigating medical ethics, insurance, and faith in medicine. تفضل دكتور. Yes. Dr. Nasser, a brother, consultant gynecologist. He operates also private practice in different hospitals. He was very active in Kammp. We miss him. He went to study. Now he's back. I'm saying it loudly because I need it to be vibrant again. Okay? Shukran.
جزاك الله خير. السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله صلى الله عليه وسلم. I'm going to welcome my panelists, and the first one in the list is Brother Juma Mvudi, who is an Islamic finance practitioner holding a certified Sharia advisor and advisory certificate from AAOFI, that is in Saudi Arabia and Dubai. He also worked in Islamic finance field for the last 15 years. He's been recently involved in the setting up of the Tanzania Takaful regulation in Zanzibar, and another one which we call First United Takaful in Dar es Salaam. He also works in neighboring countries in the southern African countries like Zambia and Namibia, if I'm not wrong, on the same field. Welcome, Brother Juma Mvudi. He's also a graduate of Sudan, and he's not from Kongoya. My second guest is none other than our brother, our father, Abdullah Ahmed Mazrui, who was born and raised in Nairobi, not in Kongoya. I have to stress on that. Takaungo, yeah, mashallah. Yeah, so he did his bachelor's degree in the UK, and also did his master's degrees in law. And then he came back to Kenya, where he joined the Kenya School of Law. And then he's been very vibrant as far as Islamic sermons and preaching is concerned in the country. You all know him. He's currently working in his firm, AA Mazrui and Advocate, which is based in Mombasa and Nairobi, if I'm not wrong. Yeah, and the last but not least is our brother, famously known as Abu Najma. Abu Najma, the first chaplain in the history of Kenya. Imagine. So Abu Najma, we give you. So he graduated, his first degree was actually from Sudan, International University of Africa. They never met with Mvudi. Mvudi is an old guy. And he's also working at Nairobi. Now he's undertaking his master's degree at Daystar University on chaplaincy. Welcome, Abu Najma. So, Karim.
Should we spell out?
No, it's okay.
Okay, sir.
So I think I'll start with, I really wanted to start with Sheikh Abdullah Ahmed, being on my right, and I will start with him. Brother Abdullah,
now,
we know we have what we call the medical malpractice issues in Kenya and litigations which are always follow such incidents. We have Muslim families and Muslim patients, mashallah, when something bad happens, we have that thing of Qaddar Allah ma sha fa'al. But we also have some people, even Muslims and non-Muslims, who feel like, no, something went wrong. And we end up in courts.
Yes.
So what are the do's and the don'ts which we should always put into consideration, either before these things happen or after they've happened and we find ourselves in courts?
Okay.
What will you advise us?
Okay. Bismillah, alhamdulillah, wa salatu wa salam rasulullah. Assalamu alaikum wa rahmatullahi wa barakatuh. I will just start by, first of all, congratulating Muslim doctors. You are ahead of the curve. We have quite a few Muslim lawyers today as well, but we're not as organized as you. MashaAllah, you guys are organized, or maybe I'm seeing it superficially, I don't know. But you seem to be organized, have got your act together, you're doing annual conferences, you're trying to support each other, guide each other, fantastic. You're well ahead of where we are. So that's number one. Number two, also congratulate everybody who's come up here. Mashallah, you've kept to time. And as you know, lawyers, when they speak, sometimes they overreach. So I'm impressed by that as well. May Allah continue to guide you and put you on the straight path. May you be useful to your ummah in the dunya and successful in the akhirah. To answer the question, medical malpractice. Yes, it was not so much prevalent previously, but it has become more prevalent recently. More people are starting to question and second guess. More people are ready now to question and second guess the medical treatment they are getting, and especially when it comes to surgical cases, I think, more than just the normal outpatient treatment, inpatient, hospitalization, surgical cases. So it is coming up. And it is something that you need to be aware of. Now, what are the do's and don'ts? Basically, you're a professional, you're a Muslim and you're a professional. So as a professional, they are supposed to be, as a general rule, the understanding of profession historically is that people who have a certain discipline and have certain standards that they maintain within that discipline that they operate in. So there's some basic standards that you must maintain. Basically, whenever you're treating a patient, you have to maintain a basic professional standard so that no other professional, and actually this is actually the way the courts measure it, that no other professional looking into that case, had they been in your shoes, would consider that you are neglectful. That is basically the standard you must meet. That your fellow professional, had they been in your situation, should not see that you actually were neglectful or did not reach the basic standard required. So this is very important. You must maintain the basic standards, which means not only what you learned in university, but all of these sessions that you have of continuing education. I'm sure you have such sessions generally, isn't it? And I'm seeing in your conference you organize that. It's very important to keep up with the latest trends, events, treatments, to try and always maintain a good basic standard and improve it going forward. If you meet that good basic standard, then basically you are not liable. Then you are not liable. Then basically it is one of those scenarios where you tried your best or you did to the best of your ability, but it did not succeed with such and such patient. So that is basically the standard you want to have. So the don't is the opposite. You shouldn't be lazy, you shouldn't be neglectful, you should not take things just, unfortunately we live in a society which is not Islamic, we're all aware of this, and we know that medical side, legal side, we have this problem that professionals are in it just for the, many of them, not all of them, many of them are in it only for the money. So you look to this client, to this customer, what you call patient, you look to this patient and you're like, what can I get out of him or her? That is the wrong attitude. Islam rejects this attitude. You should never have this attitude when you're dealing with a patient. But it is there in the general society. So when this patient comes to you, if you're affected by the general society and don't maintain your Islamic ethics, you will be looking at how can I get the maximum monetary benefit out of such and such person, instead of how should I best treat him so that he does well. There's a legal joke. I'll finish very quickly. There's a legal joke that it's a joke, but take the moral behind it. That a new family member, a son or a daughter, enters into the family practice, and then is given a file. It's been there for a long time, 20 years or so. And now she looks at the issue, he looks at the issue, and quickly he solves the problem with the client. He goes to the father, says, oh Dad, you know that file you gave me, 20, 30 years it's been with us. You know I've solved his problem. He says, son, you are very stupid. That is what educated you, that file. You see that wrong attitude? The attitude that you're taking advantage, you're exploiting for the lawyer would be the client, for you patient. Run away from that attitude. That attitude is dangerous, it's unprofessional, it will expose you to many medical malpractice suits, and it will be disastrous on the day of judgment. So that is it in short.
Thank you, Sheikh Abdullah. I just want to come back to you on issues of documentation.
Yes.
How heavy and how grave do you take such issues when it comes to court? You know,
yes.
Our courts are like, what evidence do you have?
Right. Really, basically, it will come back again to what are the professional standards of documentation, which as a general rule, you must be maintaining to be sure that you treat your patient correctly. It's basically what is the professional standards on that? What type of documentation is necessary when a patient comes in, first of all, to be treated so that you know who they are, their background, what type of, questions that you ask them to try and identify what is the problem and try to address the root cause. And then when we come to surgical cases, obviously, as they become more serious, then more documentation is required, isn't it? There should be consultations and treatment notes until you reach a position that, okay, basically the recommendation is a surgery needs to take place. And don't take it the wrong way. Don't take it the wrong way. If your patient requests a second opinion, give them that right. Allow them. It is good for you yourself. Maybe the second opinion will point out something you haven't, or most likely it will actually support your advice, which is good for you, isn't it? Going forward, you'll tell that if anything reaches court, you'll say, by the way, my patient also went for a second opinion, which confirmed my diagnosis, and then we tried our best when we went to surgery. The final point is, I agree, there is a lot of burnout in professionals in general, in legal side and medical side. I know more the legal side. You're discussing the medical side. Be careful that you don't push yourself too much, and then you perform the surgery. Some of them is very critical. Obviously, you guys are dealing sometimes with life and death issues, and it's very critical that you are on point and you are very sharp. And if you are burning out generally, or in that day because you have been overwhelmed, you need to try and find a solution for that, because the blunders that can take place there, could lead to death, isn't it? Yeah. So you have to be careful of that, inshallah.
Shukran, Sheikh Abdullah. Let me go to our brother Mvudi, Juma. As we're still talking about medical malpractices and the issues which can arise from such, we have an indemnity cover, which I think is part of your field, insurance and finance, and it's part of the Kenyan requirements for us to register or to renew our licenses. We always encounter questions as Muslim doctors, like someone will ask you, is this indemnity cover halal? As in, people will ask you, we know insurance, there are a lot of things, in exception of NHIF and all those things, and they say, we've even had fatwas from Nairobi and Jamia Mosque telling us that you can take NHIF, it's halal. But there are very few fatwas, there are very few people talking about the indemnity cover for doctors and for nurses and the medical practice. How can you just open our eyes on it?
Thank you, Dr. Abdullah. And I also like to take cue from my elder brother, Brother Abdullah Mazrui, in congratulating Kammp in having these sessions that they have for their members, to educate them, to put them at the same level, and just spread the knowledge, just build their capacity and all that. And then I also want to make a point on the question that Dr. asked Brother Mazrui. I think the question of malpractices in the medical profession is grievous in the sense, even from a Sharia perspective, in the sense that the Sharia was so serious on this issue that it actually placed a sin on a community that does not have medical professions. It is that serious. We all know that for a community to have a medical profession is fard kifaya, So if a community does not have a medical profession within its, ambit, within its members of the community, then that community is actually, committing a sin. It is that serious. So the medical malpractices, juxtaposed on this Sharia view, you need to be, very cognizant of what the Sharia, the importance of having medical professions and the seriousness that the Sharia takes upon the medical profession up to that level, that a whole community will be considered to be in sin if they lack a medical profession in their midst. So coming back to Brother Dr. Abdullah's question, I think the whole issue of professional indemnity and insurance in general is an issue that actually disturbs all of us. Because here we are Muslims and we want to, practice our religion in everything that we do, but here we are faced with a situation whereby there's sometimes you cannot do without. Like the example that he's given, the Terry has given. You're a medical profession. The law says you can't practice without the professional indemnity. But all the professional indemnities are from the insurance, let me call them insurance companies. But the alternative that the Sharia has placed is what we call the Islamic insurance or the takaful model. The takaful model. I know when I say takaful, everybody moves their mind to takaful insurance of Africa. But that's just a name to it. But it's a whole concept. It's a whole concept that actually, you know, let me say sort of negates the idea of insurance and all the malpractices that we associate the insurance industry with. Now let me give a comparison of what is insurance as opposed to takaful. Now, insurance in general, you're just trying to do what? To mitigate against the risks that you feel that you might suffer in future or in the present. So basically it's just risk management. But now the question comes in, how are you managing this risk? Are you using means that are acceptable to Sharia? Are you using means that will preserve the rights of whomever that you're dealing with? This is what the takaful concept brings in terms of risk management. So in takaful, what you have is that, no, not in takaful, in Sharia, what you have is that all financial transactions must be based on some form of a Sharia compliant contract. Any contract, any transaction at all. And alhamdulillah, the Sharia has provided us with over 40 contracts that can be used. I know you've heard of the diminishing musharakas, the murabahas, the wakalas and all that. But these are only names that actually need to be given a body. They need to be given a spirit so that they operate and the Muslims understand that this is actually Islam being practiced here. Are you with me? So what the Sharia says is that contracts are normally divided into two. And I hope I'm not taking too much time. Contracts are divided into two. Najua mimi ni mwalimu na walimu wapenda kuzungumza. So two contracts into two. One is what we call an exchange contract, where I give you value and you give me value in lieu. Are you with me? The second contract is what we call a non-exchange contract, where I receive value from you, but I'm not obligated to give value to you. Are you with me? So the Sharia has placed the conventional insurance model on the exchange contracts category, whereby when you go to an insurance company, let's say you're getting the professional indemnity. Here you are, you're normally given a limit, isn't it? It is Dr. So-and-so, you are given a limit of, let's say, 10 million. And then the insurance practitioner calculates the premium, isn't it? So the Sharia says, in this case, what you have done is actually you have transferred your risk. You have transferred your risk to the insurance company. So what you have done is actually you have paid the insurance company something for them to manage your risk for you. So that whenever a claim comes from a patient who has not been satisfied with your service, then the insurance company comes in and does what? Does the compensation. Are you with me? So this is the kind of exchange contract that is there. Sawa sawa. But now, here's the catch. In an exchange contract, or any kind of a contract, that is you're selling something, you're leasing something, and all that, what do you expect from the counterparty? A value in return, isn't it? A value in return. In professional indemnity, what value in return do you get? In most cases, nothing. You just pay the premium, and when the time comes, you still pay another premium, isn't it? Basically, the insurance company just takes the premium and then waits for a calamity to happen. I'll give you an example. I'm buying some loaf of bread somewhere, and then I go and pay the value for the loaf of bread. That's the example of the insurance model. After paying for the bread, this shopkeeper tells me, Bwana Juma, itabidi ungoje mkate wako mpaka kesho. Yes, that is it. And that kesho might never come. That kesho might never come. That is the analogy, or that is the analogy of the insurance model. The insurance model. So Takaful rectifies this by changing the contract from an exchange contract to a non-exchange contract. It's a gift contract. It's a contract that actually does what? It encompasses a bit of charity. Encompasses what? A bit of charity. So in Takaful, what we say, the insurance company receives nothing, zero, other than a commission for managing the fund that has been created by the policyholders to indemnify themselves. Am I making sense? So imagine ourselves, we have decided that we have a risk, a common risk, and we say that for this risk, for us to mitigate against this risk, every one of us needs to pay 1,000 bob to a certain fund. Are you with me? So that at the crystallization of this risk for any one of us, then this particular fund comes and compensates us. Are you with me? And then this fund is now handed over to the Takaful operator. That's what we call a Takaful insurance company. Takaful operator to do what? To manage. And for that, they get a commission. So they'll do all the technical work. You know, they will set the standards for people to be admitted. They'll do the claims and do all that. So if in this manner, the professional indemnity is managed, then it becomes not in contrast with Sharia principles. Are you with me, ladies and gentlemen? So at the end of the day, you have a group of people coming together to indemnify each other. That is where the charity comes in. So if I don't get a calamity, then obviously my counterparty, my member of this fund, gets to do what? Gets the compensation. So I've actually donated some of my funds to them so that they're compensated during the time of need. I hope I've answered the question.
Thank you. I think it's very insightful. There are a lot of questions which will arise from that, but for the benefit of time, I'll move to my last presenter, who is Abu Najma. Abu Najma, we are toning down kidogo. Juma was so loud. Being the first chaplain in this country, what are the challenges you're meeting, and what are the things which you think you've brought? What are the goodies? What are the advantages? What are the positives of having a chaplain in any facility? You think now you'll openly come out and say, look, we need a chaplain in Coast General Hospital. We need a chaplain in this hospital because of those goodies which KNH is really enjoying right now.
Naam, alhamdulillah, salatu wassalam ala rasulillah. First of all, I'm grateful to Allah subhanahu wa ta'ala. In Kenya, we have more than 10,000 Muslim graduates from Medina, from Sudan, from Azhar, Coastarians, Northeasterners. But imagine mtu wa bara ndio Allah alimchagua kamweka hapo.
Allahu Akbar.
So I'm grateful to Allah for that. وَرَبُّكَ يَخْلُقُ مَا يَشَاءُ وَيَخْتَارُ مَا كَانَ لَهُمُ الْخِيَارَ. It was the choice of Allah subhanahu wa ta'ala for this job. And only Allah subhanahu wa ta'ala understands why would a street gangster, turned into an imam and then now he's a chaplain. So I'm grateful to Allah subhanahu wa ta'ala. Number two, the good is, I'm always grateful after Allah for the doctors, for the professors who are here, medical students, and so many others who fought for this office, including our brother Dwale, Honorable Minister. He was all behind this, and so many others, maybe some of them have died, Dr. Abdallah and many others who fought for this office. After all that, I think there is so much, my role there at the hospital is very critical. As I had mentioned, there are some revert cases here and there. But the first thing when I arrive at the hospital, and it's amazing to me, you do your rounds up, you go to this patient. Now the first thing you tell them, mambo ya sala, and they're like, ay, yani mini, unaniambia sala. Apa. So even I'm shocked, when you remind them about Salah, and now you have to educate them that, in this condition, you have to pray. أَوَّلُ مَا يُحَاسَبُ بِهِ يَوْمَ الْقِيَامَةِ الصَّلَاةِ. You teach them their challenges about making wudu, you do tayammum, you don't have to face the qibla if there is nobody to assist you in that. We have issues of musalla. Right now I'm trying to develop a Muslim-friendly musalla. Sujui tutaika kotona manini, the doctors will advise us. Because the material one, I think, transmit the germs and water. So I'm thinking of that. Friendly musalla to give to the patients. There's so much programs that I've been able to achieve since I came in. We have Salatu Taraweh Ramadan. We're able to give iftar to the mothers who have been admitted there, wale wa mama kona watoto wao, pediatric wards, orthopedics patients. We pray Salatul Eid in the masjid there. We celebrate Eid, including all, if not some of the staff members there. We have an Eid program. Thank you to Kammp. Kammp will to sponsor pilau. I think this was last Eid. Through Dr. Nasir Mulituchangia, we were able to do pilau. Dr. Binagil restaurant in Pangani wakatengezea pilau mzuri ya Kiswahili. Mashallah. So thank you, Kammp, for that. So there's a lot of programs that I've been able to do. I'm doing also madrasa wale patients with cancer and also those who are able. We teach Quran also. We teach memorization. Duksi there, they're memorizing. Some of my patients at 1E, they're memorizing the Quran. Also the doctors. Wengi hawajui Quran na lugha ya Kiarabu. Yeah, so they come privately. Na nawasomesha in unbanibinmun. Yeah, so I have some of these also doctors. And mashallah, the khutabs. We have, since I came in, we've never failed to have a Friday khutbah. We have khutbahs. And alhamdulillah, through my khutbahs, I try to challenge the doctors to be more Muslim, And we also have, once a month, we have a staff breakfast. Nakutana with all the staffs. Pale Kenyatta, kuna mwanamke mmoja mgunya anapika vizuri. Tunahakikisha doctors wetu in that breakfast wanakula vizuri. Jazakallah khair.
Jazakallah khair. Abu Najma, I have to remain with you. There's another final question I should ask you.
Yes.
As we are salivating on viazi karai from our...
Yeah.
Abu Najma, yesterday we really talked about institutions. Dr. Tahir talked about institutions. And the chief guest whom we had in our first plenary also talked about institutions as very, very primary in fostering our brotherhood and at the same time to come up with plans and how we are going to implement those plans.
Mm-hmm.
So for KNH, you are very lucky that you have a mosque. And we know that even in our Islamic history, majority of the decisions were made inside the mosque. Even the Jeshul Usra, if I'm not wrong, all those decisions and making everything was done in the mosque. And I've just realized that with a mosque, there's that sort of brotherhood which is being built and people feel like they are free to each other. And you are coming from International University of Africa where all the notices and everything was done in the mosque.
MashaAllah.
Sheikh Abdullah has been to International University of Africa and you've seen the way they are utilizing the mosque. How much can you emphasize on the importance of having a mosque in all Islamic or in all hospitals, specifically in hospitals which are in Muslim populated areas, like here in Coast General, where we don't have a mosque currently?
Before that, there is something which is very important, least we forget. I think right now, as Dr. Shaush had talked about it briefly in the morning, that me at my office level as a senior chaplain for KNH, Kammp through Dr. Jalab and Shaush and Bajabir, and also our doctor, Dr. Mewa Doctor. Dr. Abdullah Khatib, we are trying to develop a curriculum, a syllabus. We've been doing that, I think, for the past 8 months. I've been coming to the coast often. So we are trying to develop that because up until today, we do not have an Islamic curriculum for Muslim chaplains. And the courses which we have been doing and the hospital has paid for me, mostly is based on Christianity. And the spiritual care for Muslims is not really there. And the other day, we were having a meeting with the hospital, and I was telling them that there is a lot which is missing in your, for Muslims here. We are not anywhere. So there is a need for that. And I pray to Allah subhanahu wa ta'ala that will be possible too. I was requesting Kammp, if sijui kama you have those plans. If you not, then you would really assist us next year if you have it. All these courses that we've been trained here, yani ni big courses. Kenyatta can pay for you 250,000 just to attend 2 days. 250,000 to attend these 2 days. And yet you come out without any certificate. You know, for us, if maybe this would have been arranged, you know, we did these courses for 2 days, you know, this is the certificate, it would add something to our HR. Maybe neza ongezewa 10K when I give this to HR. So it's important that at least we get this certificate. If it's not there, maybe next year, it will, even some of the clinicians here, tumtutu wetu tudogo tuko hapa, those papers would really matter. Maybe it wouldn't matter to the doctors and professors, but it would really mean a lot. I think mosques are very important, as you said. Now, basically, at the we are advocating for that. And the other day, we were with Dr. Nabila. We went to Mathare Mental Hospital. We talked to the CEO, and I told the CEO how we are working it out in Kenyatta, how it works and what. And the CEO, through Dr. Nabila, he promised us that, inshallah, they are going to recommend it. They are going to at least make sure that at least anytime soon that we could have one. Right now in Kenyatta, they're in the process of adding another chaplain for me, because the Christians are 8, 9, and I'm the only Muslim chaplain, so it's an office for that. And also many other hospitals are thinking about it. The other day, there was a delegation from KU, the chaplain, the Christian chaplain from the Protestant church, another delegation. They came to my delegation. They came to my office, and we had a lot of questions. I took them through our trainings and courses and what we do, our mandate, our roles. So there's a big awareness about Islamic or Muslim chaplaincy, and inshallah there is a lot that we are going to achieve. And lastly, if you can ask me, right now I'm a chaplain, senior chaplain at KNH. Where would I be like 10 years to come? Inshallah, I pray to Allah that one day I'll serve as a board member of KNH, and when I'll be there, inshallah, some of all this will be possible, inshallah.
Jazakallah khair. Shukran. Abu Najma, now I want to get back to Brother Mvudi. I have a very hard question for you here. How can the financial aspects of healthcare be structured to respect Islamic ethical standards? You got the question, what?
I did, but I'll need some clarification, because there are two things that are, to me, are contradicting. There's the financial bit and there's the medical bit. And I'm struggling to see where these meet. Kindly elaborate.
We have both sort of takaful on how we are going to, sponsor ourselves as far as bills are concerned. For example, we have a patient who has died. We have a hospital which has to make money. We have to do what we call sitri to our brother or a sister who has died. But at the same time, their gloves which were used, their medication which were used, everything which was used. So how do we come to a balance in such a way that we are going to make sure that we maintain the Islamic aspect on one side, but at the same time, there's this financial part which is itching us. What balance? Can you give me a sort of a way forward? Because we always receive such messages in our WhatsApp group, the date wamekufa, please send. But now, Dr. Kandwala will tell you, come on, man. I have a payroll of I don't know how many people. They need to be paid. I have Syntocinon. I have Ceftriaxone, which was bought. And the suppliers are on my neck. You see, how do we balance these things Islamically?
Thank you for that question and the clarification, Dr. Ari. I think the aspect of having patients that are not in a position to cater for their bills is something that is, I think, a big worry for all of us. And Abu Najma will testify that a mosque in Nairobi, Park Road, I think is it weekly? And even in Jamia Mosque, we always receive these kinds of cases. Aya jamani, kuna mwenzetu amefariki, yuko mochari, hospitali hii, bili inapanda, na vitu kama hivyo, haya tuchangeni. That is how we have been handling our situations. But I think there are better ways of doing this. There are better ways of doing this. And, you know, handling emergencies, or let me say what, risk losses or urgent cases requires some sort of preparation. It requires some sort of preparation. So my idea would be that we be the philanthropic persons that Islam urges us to be. And you don't need to contribute so much to a fund. We can have a fund that any one of us contributes to. We have been doing forceful contributions to the NHIF because it is, you know, I specifically use forceful. Specifically use forceful. Because the NHIF, yes, you contribute, but do we feel its effect? Do we feel it? I think even you as medical practitioners feel the opposite of the effect, the negative effect. When you present your bills that you have to wait for several months for it to be settled, isn't it? So can we as Muslim practitioners, as Muslim leadership, as Muslim community, have our own fund? Can we have a waqf for medical cases? Can we have a waqf for medical cases? And I think that question comes back to me. Dr. I know you know that our friend, Dr. Bulushi, is the CEO at Waqf. I think this is something that we need also to bring him to attention to, so that, sir, what can we do about this? What can we do about it? There are these cases that, you know, they are ever increasing, and I'm sure they come to you. You have a whole, you know, Waqf organization with resources all over. What can we come up? What can we come up? And it's been done elsewhere. It's been done elsewhere. There are places in this world, countries in this world that actually have these kinds of awqaf that solely cater for medical emergencies. So I think coming together and forming that waqf, that fund that is going to be taken care of this. And the contributions don't have to be so much. They don't have to be so much, because if you contribute the whole lot of us, some small contributions, that will amount to a lot, and inshallah it will bring the effect that is needed.
Yeah, thank you, Brother Juma. I think, as we've mentioned, majority of these patients actually, they don't even have that NHIF. That is where the problem starts. So I think even as Kammp, we should try our best and try to, you know, tell these, you know, we ask ourselves, how many of us are paying their premiums for their mothers? Okay, it's just your mom and your dad is one premium. It's just 500 shillings. And then we also have sisters. Have we pushed them and tell them, look, my sister, you should have an NHIF? At least as much, as low as these things, they help. But at the end of the day, it's not the same. I'm sure you'll not be laid in that mortuary of course general, waiting to be cleared of your bill if you had an NHIF. The least is that at least an NHIF will pay for you.
At KNH, me, Dr. Hussein, and the Muslim staff at KNH, what we've done is that we have our own contributions where we pay for all the Muslims who are admitted there who do not have NHIF. And in fact, one of my roles is when I attend the patient, I ask them, unalipa aje, you know, do you have NHIF? So one of my roles is to ensure that they all have NHIF. Hata mwingine anaambia natoka kesho, naambia lakini ugonjwa haitoki kesho, utakaa mpaka mwisho itakuwa. So you still need it.
We really need that sensitization program as Kammp. Lastly, benefit of time, I think it will be very, very unfair to our brothers of Palestine if we don't mention it as a qadiyya on what is happening currently in Gaza. I just want to give Sheikh Abdullah 3 minutes to tell us, as medics, more so because after lunch, I think we have a skills station where we'll be talking about mass accidents and mass, you know, those things. What is the role of Muslim medics in such scenarios where we've found ourselves in a very needy situation like that, on what is happening to Gaza and what is the solution?
Bismillah, alhamdulillah, salatu wassalamu. If the situation in Gaza has not moved you, if it has not made you cry, it has not made you bleed inside for your brothers and sisters, wallahi, I do not know what will move you ever in this dunya. And my advice to you and to myself, is that, remember, everybody is responsible and will be accounted. كُلُّكُمْ رَاءٍ وَكُلُّكُمْ مَسْئُولٌ عَنْ رَعِيَّتِهِ. And those whom Allah has favored and endowed with more ability, competence, authority, influence in the ummah will be accounted more than the one who has less. There's no doubt that the ummah looks up to you as doctors, looks up to us as lawyers, looks up to lecturers. So those, we have some influence. We must use this influence correctly. Now, I have 3 minutes. I just want to mention 10 points. Our job as those who have a bit of influence in our family, in our community, in the general society, is to speak the truth and call for the correct solution, whatever it costs. It has costed our brothers and sisters in Palestine their lives. It is costing their lives as we speak. The least you and I can do is speak the truth and refuse to accept and to submit to false solutions. So I have 10 points very quickly I want to point out, which will coming historically until we reach the situation today. How did we reach here and how do we move forward? Number 1, Palestine is a blessed land. Was mentioned in the first ayah of Surah Al-Isra. It's a blessed land. Any Islamic land, we should fight over it if somebody tries to steal it from us. What about the blessed land of Isra and Miraj? You cannot abandon it. You cannot neglect it. Number 2, it was conquered under the Khilafah of Sayyidina Umar ibn al-Khattab. Many lands were conquered under his Khilafah. But you know, it is the only place that Umar ibn al-Khattab left Medina to go himself personally as the Khalifa to take the keys of Jerusalem. That was how honored that land was. Number 3, it has been taken before in our history. This is not the first time. The first time was taken by the Crusaders. The Crusaders came and they had multiple crusades, and in one of them they were able to conquer Jerusalem, and it was out of our hands for many decades, but the Ummah never abandoned it. And they took it back, and that is the 4th point. It was liberated by Salahuddin al-Ayyubi rahimahullah, a Kurdish leader, but acting as a Muslim. Get away from nationalism and racism. It's destroying us. Divide and rule is killing us. It's killing the Ummah. If we do not think and act as Muslims on the basis of Islam, we are destroyed. Salahuddin al-Ayyubi liberated Palestine, but first of all, he united the Muslim lands. The same thing happened today, that some of the Muslim rulers were divided, confused. Some of them worked with the enemy, worked with the Crusaders to allow them to enter the Holy Land. So Salahuddin al-Ayyubi was not able to reconquer, to liberate Palestine. First of all, he had to deal with the corrupt rulers of his time, and he overthrew the Fatimid rulers. And he reunified Egypt with the Abbasid Khilafah. And now, as a commander under the Abbasid Khalifa, he fought and he liberated Palestine. Point number 5, that under the Khilafah was when this land was protected, and it was protected for all, Christians and others. And that is why the enemy, when they came up with this Zionist movement, the Zionist movement is like 1.5 centuries maximum, if that. Samuel Herzl, the leader of the Zionist movement, he tried to approach one of the last sincere Khalifas, the Khilafah Uthmaniyya, the Ottoman Caliphate. He went to Sultan Abdul Hamid and he offered him a lot of money. He tried to buy Palestine from the Khalifa. Sultan Abdul Hamid, what did he tell him? He told him, by Allah, I can never give it to you, by any money, because this was a land on which the Muslims died to protect it. But he told that Jew, he told him, but if there comes a time that you have destroyed the Khilafah, then you will get it for free. And that is exactly what happened. When we lost our Khilafah, that is when the land was taken. And it was not taken by the Jews. They don't have the ability to take it from us. They are cowardly people. You're seeing it yourself. They cannot fight. But it was taken by the British, which was the greatest contributor to the destruction of the Ottoman Caliphate. And then they entered into the Muslim lands generally, and they did what was the Sykes-Picot division of our lands, and they divided into 2 mandates, and Britain was given the mandate over Palestine. 1917 came the Balfour Declaration. The Foreign Secretary of Britain in London promised to Samuel Herzl that they would give the Jews a homeland in Palestine. A British foreign secretary gave up the blessed land as if it belonged to Britain. If they love these people so much, give them Britain. Give them America. Give them Germany. You love them so much, you support them so much. Tell them to come. Each one of them has dual citizenship anyway. They are there as occupiers and thieves. They don't even really believe they belong. That's why they have multiple passports. When things get tough, what do? They run away. Then, after the Balfour Declaration, and this only came about when British took over that land by the treachery of the Arab rulers who were granted kingdoms, and you know who they are. Because of their treachery, the British came in, promised the land now to the Zionists, and then after 31 years, in 1948, this so-called Zionist entity was created. How can they claim to have a historical attachment to Palestine, and they've only been there 75 years? When we have been there more than 1,400 years, subhanallah. From the Khilafah Sayyidina Umar is more than 1,400 years that land was ours. Come people who have a birth certificate of 75 years ago says this land belongs to them? My dear brothers, it was created as a colonial enterprise, and that is why it is wrong for any of us to call to the United Nations as a solution. Who is the one who gave the Zionist Palestine? It was given by a UN resolution. And that is why our brothers have been crying and screaming, international law, international Palestine law is being broken. There's a genocide being committed in front of our eyes. And has the UN done anything practically about it? Has the ICC done anything practically about it? Do you expect they will do anything? When the ICC, the UN, all these international institutions are controlled by the Western powers. Today it's America who inherited superpower status from Britain, who is the greatest patron and supporter of this enemy. So do not call for international institutions or international humanitarian law or ICC. They will never solve this problem. This is an Islamic issue, can only be solved Islamically. What is the solution? This solution is known from the deen by necessity. The same way we know that we must pray and we must fast. Ma'lum min ad-dini bid-darura. There can be no second opinion. The only solution when an enemy enters into Islamic land, conquers it by force, is that we meet force with force. There's no other solution. The only solution is jihadun fi sabilillah. Now, had we not had armies and weapons, we would now see how we organize ourselves. But is not the whole of Palestine surrounded by Arab and Muslim countries? Do not each one of these Arab and Muslim countries have armies? What are those armies for? Do you know that the Muslim countries spend more than $200 billion on their military budget? The whole of the budget of the Zionist entity is less than $10 billion, including the support they get from the West. And they are cowardly people. They are few million. The ummah is 2 billion. How can an ummah of 2 billion who have 57 Muslim countries supposedly under the OIC, which is another corrupt institution, which they spend $200 billion annually. We have millions of soldiers trained to fight, yet they are never given orders. Why not? Who has betrayed us? It is the rulers in the Muslim countries, agents and hypocrites, every one of them. By Allah, the solution is jihad. The Muslim armies must be mobilized to fight to liberate every single inch. Don't talk nonsense of 48 and 67. The whole of Palestine is Islamic land, and we must reconquer every single inch. The Muslim armies must fight, but they will not be given orders by these corrupt rulers. So what becomes the duty? Innahu ma la yatimul wajib illa bihi fahuwa wajib. If these rulers are preventing jihad, they're not only preventing jihad, they stand with the enemy. Subhanallah. They stand with the enemy, and they actually support the slaughter of the Muslims. Wallahi, I'm not lying. If they are the ones preventing the solutions, if they have betrayed us, if they prefer kuffar to Islam, my dear brother read that ayah, wallahi, that is like Allah had just, لا تتخذ المؤمنون الكافرين أولياء من دون المؤمنين. Clear cut, we cannot have alliances. Forget normalization. These people have alliances and strategic partners to the greatest enemies, not even the Jews. The Jews are cowardly. It is the West. You see how they brought their fleets and their armies and their murders to support slaughter and genocide of Muslims. Wallahi, they must pay the price. and we must fight jihad. It was taken by jihad under the Khilafah Sayyid Umar. It was liberated by jihad by Salahuddin al-Ayyubi, and today there is no other solution. Jihad, but this jihad cannot be fought under these corrupt agent rulers. So all Muslims, we must go back to Islam, unify on the basis of Islam, bring back a sincere leader, a true leader. Amirul Mu'minin, the Khalifa. They got rid of the Khilafah Uthmaniyya, they got Palestine for free. If we bring back the Khilafah, which the Prophet ﷺ told us, ثُمَّ تَكُونُ خِلَافَةً عَلَى minhaj nubuwa, and then the Khilafah will come back on the way of the prophethood. That Khalifa would not sit for a second and allow this nonsense to take place. My dear brothers, this is the clear talk we must all talk. You are in your WhatsApp groups, you are in your live discussions. Talk the truth, speak the truth. Our brothers and sisters are being slaughtered. Our children, more than 5,000, subhanallah, have been bombed. Are being burned to death by white phosphorus bombs. If we cannot speak the truth, wallahi, the least we can do, and I don't know if that will save us before Allah on the day of judgment, if all we do is speak. But that's the minimum we must do. Cannot accept this situation is unacceptable. And it only came about because we Muslims became confused and we became westernized and we detached ourselves from Islam as a way of life and started following false ideologies and being nationalistic and racist. And despite all our numbers and these great professions that we have, if we do not organize ourselves and get our affairs in order, wallahi, if they can do this to the blessed land, in front of our eyes, what can they do to you and me and my son and your daughter and your wife? Wala hawla wala quwwata illa billah.
Jazakallahu khair. Allah. Barakallah. That brings us to the end of this discussion. Jazakumullahu khair. Thank you for listening. Shukran sana Sheikh Abdullah. Shukran Sheikh Vudi. Na shukran Abu Najma. Barakallahu fiikum. Subhanakallahu wa bihamdika. Nashhadu an la ilaha illa anta. Nastaghfiruka wa natubu ilayk.
Shukran, Jazakumullah khair. We are 1 hour late. We are going for a break. Please, we have those who have collaborated with us in this conference, made us possible to sponsor a good number of participants. So they have booths. Kindly visit them. Thank them for participation. Signed their attendance list so they see that they are appreciated, and we'll have them in our next meeting also. With all that, inshallah, now I'll take a break we target by 11:20, we'll be kicking off the next session, okay? And all other subsequent talks, please, will be minimizing 5 minutes or so to save time. Thank you very much.